Hello and welcome to Exercise Etc. Standing Tall, Exercise in the Aging Spine. My name is Laura Abbott, and if you have heard me before, welcome back. And if not, this page just kind of goes through just a brief little bio. Mainly just you can put the face with the name of the picture and all that good stuff. So I'll let you really want to read that later, you can. But some more important information here. If you've done our webinars before, you know that you can get your certificates immediately following. And if you're new, hey, guess what? You can get your certificates immediately following the webinar. So you'll see this at the end of the presentation, and you may have printed out your notes as well. But you will log into the exerciseetc.com website once we are done with this webinar. And you will go to the administration link and click on that. Then you'll go to the webinar on demand certificates and click on that. And then when you get to the next page, you need to choose the exact title of the webinar. And again, this one is Standing Tall, Exercise in the Aging Spine. The reason is we have some titles that are similar, and if you pick the wrong one, then you're going to be wondering why you can't get your certificate. When you're done doing that and picking the title, there is a 20-question quiz that is required afterwards, and once that's done, you'll complete a very quick little evaluation. The evaluation helps us out as far as continuing to work on improving as much as we can. So your suggestions are very valuable. And once all that's done, you will eventually get to a Get Certificate button, and you'll click on that. You'll complete the certificate, and I always recommend completing the certificate with your name the way it is with your credentialing organization, just to make things easier. And then you will get it emailed to you. Always make sure to save a copy on your computer. Also, please note that you do need to complete this webinar and print your certificate by December 31st of the same year that you ordered it, because some credentialing organizations will not accept next year's date. And about the quiz, your webinar quiz is based on the printed material, not on the lecture. So the questions come straight from the PowerPoints pretty much. They are sequential and follow the outline. So just keep that in mind when you take your quiz. So let's get started. That's why you're here. So with back pain, so many people have back pain. We all know that. Even some of us right now listening to this may have some back pain. It's one of the most common problems that we have. It's a reason that people go to their doctors a lot. It can be chronic, meaning it's lasting longer than about 6 weeks, or it can be acute, meaning it's lasting shorter than 6 weeks. And, but either way, it's problematic because we realize how much we rely on a strong spine to get through our daily activities. And since we're kind of zeroing in on seniors for this presentation, up to 80% of seniors have some kind of chronic low back ache or pain. And a lot of it is due to arthritis. As we get older, that arthritis is a greater risk. And also deconditioning. Sadly, a lot of times when people get older, they become more sedentary. And if you've had other presentations with me dealing with seniors, you may have heard me say this before, but when we retire from our jobs. We don't retire from life. And sometimes people look at either their age as a number or their retirement, and they say, oh, I can sit around and do nothing now. And that comes back to hurt us later if we do that. So we want to keep people active. And then the third bullet point, in many cases of acute back pain can be from some type of trauma, could be a, heaven forbid, a car accident, rear end car accident, poor lifting techniques over and over and over again. A lot of times those types of pains tend to resolve within 6 weeks, which is what makes them acute. But the challenge is they did something wrong if it's something they could have controlled, such as a poor lifting technique, and we want to know that because their technique and movement, their technique in the gym, if they're at the gym, their technique when they're doing their daily activities, we don't want that back problem to keep coming back and rearing its ugly head over and over again, because eventually it will become chronic and it could be some permanent damage that we're going to be talking about a little bit later. We don't want that. What causes low back pain? Well, there are all kinds of different causes, and we just touched on a couple on that previous slide. It's important to be aware of all potential causes of lower back pain to help educate the client. There may be a variety of both intrinsic and extrinsic factors that may be resulting in the pain. Many low back disorders go undiagnosed, or proper cause is never really established, and sometimes it could be a muscle issue that fitness professionals such as myself and possibly you can work with your client. You know, granted, this is focusing on the aging spine. The younger our clients are and learn proper form, and not just an exercise, but they need to be able to translate that over to their daily activities and be aware of when they're doing something wrong in their home, in their car, outside, whatever, to prevent some of this. And sometimes we don't emphasize it as much as we should. So if you're working with clients and they're losing their form in an exercise, then stop them and correct them and get them to be aware of where they're feeling the muscles that are working during that exercise so that they know what it feels like and they know whether they're feeling it in the right place or not. So some intrinsic causes, I mentioned intrinsic and extrinsic factors. Your intrinsic factors could include things like previous low back injury, genetics. Arthritis may have a genetic connection to it. Some of the spondy conditions might have some genetics to it. That body shape and where the pressure ends up on the spine can definitely be genetically connected. Motor control, biomechanics, conditioning, flexibility. We know flexibility is important, making sure that they're stretching what's tight and strengthening what's stretched and weak. Postural analysis, all of this all goes hand in hand, because if we're doing the wrong thing for our client or emphasizing the wrong things for our client during their exercise and stretching, then we may be helping to progress to chronic low back problems. So we really need to know our anatomy. That's the key, is we've got to know our anatomy. Other lifestyle factors can also be intrinsic causes. Are they sedentary? Do they have a sedentary job? You know, what is their life like? And then some extrinsic factors include training-related injuries, the environment, diet, medication. Some medications can predispose people to osteoporosis, for example, which of course can lead to, you know, not just spinal issues, but other issues. And then previous treatments that have been done. And not just back treatments, I mean, treatments such as chemo. You know, yes, chemo is important and it saves lives from cancer, but sometimes it has some negative side effects and some negative issues that can happen to the body. So, you know, I'm not poo-pooing any of these. It's just if some of these medications and previous treatments need to be considered so you know what you're working with. And that's also why when it comes to medications and treatments for other things, it's so important to get the pros and cons from your doctor so both of you can work together to make good decisions. So, symptoms of spinal degeneration. Pain that interrupts sleep. You know, people roll over and they wake up because their back, you know, catches or causes some pain. And that is kind of a double whammy, because if you're not getting enough sleep, you're not going to feel good the next day. When we don't feel good and when we're tired, we don't maintain form. So it's kind of this vicious cycle that can start happening with these back injuries. And sometimes, yeah, maybe the mattress is the problem, you know, so that's something else to think about. pain that is most pronounced first thing in the morning and again towards the end of the day. As first thing in the morning, you're stiff. And if your back is already bothering you first thing in the morning, then it didn't heal well at night. And again, it could be a sign that it could be something like your mattress or your sleeping position, but it also could be a sign that bigger things are happening to the spine that needs to be corrected somehow. And then towards the end of the day, well, you're tired towards the end of the day. And sometimes towards the end of your day, you're sitting more. You may be sitting in front of the TV, and that sitting position may not be helping, as far as getting movement and flexibility and things like that. The third bullet point, localized tenderness, when the affected area of the spine is pressed. So pinpointed pain, that's not a good sign at all. Or just tenderness, not even, the spine itself, but out away from the spine, which could be some of the tendons that are attaching those deeper muscles of the spine, multifidus, rotatories, maybe the tendons are inflamed. It could be all kinds of things, but pinpointed anything, pinpointed pain or tenderness is not typically a very good sign. And then aching, steady or intermittent pain in the lower back that's aggravated by extended activity, especially if that extended activity is using improper form. But we're also talking about pain that's just really never going away. That is a very bad sign. And then stiffness or loss of flexibility in the back, getting up out of a chair, getting up out of bed, getting, just moving, stepping over a bathtub to get into the shower. If they're stiff and it hurts, then that's not a good sign. So these are all things that, these are great questions to ask your client. And if they are having these and they haven't gone to the doctor, they really need to go get this checked and start off with that x-ray. So that kind of hits this next slide. Don't suffer in pain. So as the patient or the client's age, the incidence and prevalence of certain pain syndromes are going to increase. Changes happen inside the body. We know physiologically there are health changes. The heart's not as strong as it used to be. The lungs aren't as strong as they used to be. The kidneys, the liver, all that physiological part. But there's also some anatomical things going on as well. To the bones, to the muscles. We know that as we age, even if you're exercising, we do lose some muscle mass. Now, you lose less muscle mass if you're exercising, but you still lose some muscle mass. And if you don't have the muscles and you're trying to do the same things you did when you were 20 or 30 or even 40 or 50, then you're not going to be able to maintain proper form. You're going to start to compensate somehow, some way, and that can lead to a lot of back problems and other joint problems. And pain may also be underreported, as older patients seem to think that pain's just normal as they get older. You'll hear them say things like, "Oh, getting older is hard," and that's not necessarily true. And so encourage your client to think this way, to get some help, to go to the doctor, to see what might be able to be done, because it's something that maybe isn't chronic just yet, or even if it is chronic, maybe there's some things that can be done to help lessen the pain. So avoiding or controlling some low back or chronic low back issues. Practice good posture while standing or sitting. And that really is getting into body awareness, and not everybody has it. I'm sure we all have stories of watching the quote-unquote not-so-good personal trainers, degree certified, whatever, who are watching their phones and checking their phones and not watching their client and not watching their form. And it is our job to stop the client from the exercises, to correct them and get them back into their repetitions. And if they're starting to fatigue before they complete that set, then guess what? Either the weight's too heavy or they have too many repetitions in that set. You know, so once they start to lose their form, that needs to be their last repetition. But sometimes people don't even know what correct form is. And, you know, I worked with older adults quite a bit. Some of you have probably also. And I just remember when I would teach chair exercise classes, and I had them do some standing exercises. And one of them was teaching them how to do a pelvic tilt while standing up against a wall. And I would have their feet, their heels, maybe 6 inches to 8 inches away from the wall, so they were kind of leaning a little bit. And I'd have them place their hand behind their back, and notice that with the natural curve, they could touch their fingers together behind their back. And then I would have them place their hands, and it doesn't matter which one's on top, but for simplicity, if the right hand is on the below the belly button and the left hand is just above the belly button, so that your left pinky and your right thumb are slightly separated. And then you perform a posterior pelvic tilt, flatten the back out, whatever term you want to use so that they understand it. So now the pinky on the left hand and the thumb on the right hand are touching. Before I figured out that cue years ago, I watched my elderly ladies do squats because they thought that was, you know, doing a posterior pelvic tilt. And I really had to kind of think through my cues and came up with that one years ago, and it's worked because a lot of times your older adults haven't done any exercise and they've lost the ability to maintain proper posture, whether they're sitting or standing. So we have to re-educate, so to speak, those abdominal muscles, and that's hard to do. If any of you have ever had children, I remember hearing a young woman who had a C-section, and she said, I'm so excited. I was finally able to contract the lower portion of my abdominal muscles for the first time since I had my C-section. And it's just such an exciting thing, you know, when you realize, oh, that's what that's supposed to feel like. And a lot of your older clients need that education. They need to start back at the very beginning before they start moving forward into some of these exercises, because you can remind them over and over again about good posture, and they're not going to remember it because they don't know what it feels like to contract and hold core. So keep that in mind. Maintaining a healthy weight, that one's a given. I mean, we hear this all the time. Excess body fat, pressure on the lower back, it's just, you know, if we can help them to reduce their body fat, the better. Eating a healthy, I don't like the word diet because the first 3 letters in the word diet are die, and most people feel like they're dying when they're on a diet. But eating healthy foods, eating healthy meals, and staying hydrated. Oh my goodness, hydration. Older adults, oh goodness, diuretics. If they're on diuretics for whatever reason, they will not drink water like they're supposed to. And I get it. I mean, let's think about this. You've got somebody who has arthritis in their hips or their knees or their back's hurting, since that's the topic of this class, and they have to continually go back and forth to the bathroom because they're trying to stay hydrated, but they're on this diuretic that's making them have to urinate a lot more than most people. And having to physically walk to the bathroom and hopefully get there quick enough if they're on the diuretic sometimes, and do what they need to do to get ready to do what they, you know, do their business in the bathroom, and then have to reverse all that to get up off the toilet and redress themselves and all that, and their back hurts, their joints hurt, they've got arthritis. They don't want to do it. So what do? They either don't take their diuretic, which is not good, or they don't drink enough water. And we know that hydrated discs and your spine help to kind of reflux them a little bit so that you don't have so much bone on bone. It helps the synovial fluid in our joints. If we're dehydrated, you're going to have very little synovial fluid in your joints, and that's going to be true with all the discs and spine. So you got to kind of conquer the beast a little bit as far as what to do to get your person to drink more water. And maybe what your client or patient needs to do is talk to their doctor about when is the best time for them to take their diuretic during the day, because they also want to get a good night's sleep and not have to get up and down and go to the bathroom in the middle of the night. So got to pick that battle a little bit, but it is going to help with their aches and pains. Which kind of leads to the next thing, getting enough sleep. And it sounds so simple, but you know, if you don't tend to have back problems, if you're not getting enough sleep, what we talked about earlier is going to happen. It's that catch-22 where you start fatiguing, you lose your form in whatever activity you're doing, and then you're hurting, so then you don't get a good night's sleep, and it creates that vicious cycle. So if they are in pain and it is preventing them from getting a good night's sleep, that's a conversation to have with their doctor about what are some options. And then take steps to reduce stress on your back. Goes back to really everything we've talked about, all those bullet points up above. You know, maintain your form. Check your car seats. Make sure your car seats are adjusted properly if you're in your car a lot. I used to tell people who traveled a lot, you know, that if you have a carry-on bag that you don't mind putting your feet on, that can help in your sitting position in the airplane seat, because sometimes unless you're 7 feet tall, those plane seats won't fit you right. And if you can put something underneath your feet to slightly lift your knees just a little bit above the hips, that may take some of the pressure off your back if you're on a long flight. So check their workstation. Make sure that their workstation is set up where what they need, they have easy access to without having to turn and rotate and this, that, and the other thing, and that their seat is, or their chair is properly, at the proper height. And of course, exercise to keep your core strong and keep it functional. We tend to gravitate away from abdominal exercises that focus on the abs, such as curl-ups and things like that. And that's okay, as long as your person can, you know, engage the core in their other exercises. They're still getting that endurance core workout if they maintain proper posture, say during a squat or a good morning, a modified good morning, or a deadlift or something like that. But we also may need to go back to what we were talking about in that first bullet point with some of our older adults, is start from the basics and teach them how to do the pelvic tilt. And hey, when your pinky and your thumb on the opposite hand touch, like we were talking about, just feel the tension in your abs. Yeah, I do. Okay, well, that's what it feels like when you're engaging the ab muscles, and educate them that way. So, chronic pain and central desensitization. Pain tolerance tends to decrease as we age, and that's for lots of different reasons, especially the second bullet point. When people are subjected to long-term chronic pain, it essentially kind of rewires your central nervous system, which is the brain and the spinal cord, and that's where we get the term central sensitization. And what happens is the brain and the spinal cord, the central nervous system, goes into this high anxiety state and reacts even to minimal pressure or stimuli like severe pain, and that causes pain tolerance to decrease even more. So sometimes what seems like mild pain or mild aches to the rest of us may be very painful to your older adults because of this. So we have to be sensitive to what they're experiencing. We don't want to do anything that's going to increase their pain. And we just need to be aware that what we feel when we do something and what somebody else feels may be two different things. So we're not trying, I always tell people, we're not trying to set your clients up on our exercise program. We're trying to individualize it. And if your client, I've had clients say this, and I don't hear it as much, which is good, but I remember hearing over and over again, exercise causes arthritis. And, you know, we hear that because that was the thinking 50 years ago, and people still believe this that are in that older age group. And we have to educate them, but we also have to show them we know what we're doing. And we're not going to increase our pain or your pain. We don't want to increase it, so let's communicate. And if they're doing something that they say, this really hurts, and we're thinking, really? Gosh, I just can't believe that hurts. We need to adjust based on what our client's feeling. And that's going to help them trust us and trust our knowledge and our abilities to help them. So anything that we do, if it makes the client worse, then we either need to modify the exercise or the movement first and see if that corrects it. Give them better cues maybe, or cues that they understand better to make sure that corrects it. And if it still doesn't correct it, move on to something else. Or if it continues to happen, maybe they need to go back to their doctor and get reevaluated. And that's this last point. A referral to a pain management physician may be necessary. Again, clients should not be getting worse in this particular type situation. They should be getting better. So if they are getting worse, something else is going on, and it may be out of our scope of practice as fitness professionals, and they may need to be getting referred to someone else. So why do we need a diagnosis? Well, low back pain is not always muscular. And I even tell my students, you know, as degreed exercise physiologists, we're tendons, we're muscles. We are not bones, and we are not ligaments, and we are not nerves. And anytime you feel that one of those last three things may be an issue, go refer it out to get confirmation. The other thing is our clients are not in our field, a lot of them, right, most of them. And so they hear the doctor explaining this, that, and the other thing, and we know there's some good doctors out there that really explain things well and to the patient's level, but then there's some doctors that use these 40-syllable words, and the client's going, okay, I got it, and they really don't. And then when you ask them, you know, what's going on, they can't explain it. They don't know. And so it's good to get the diagnosis. It's good to ask the client to bring the information to you and know exactly what you're dealing with your client. Even as a degreed exercise physiologist, I have had many people think that I'm also a physical therapist. They think it's the same thing. And so you also want to make sure that your client's going to the person they need to be going to. So if you see the referral from the doctor and it says physical therapy and you're not a PT, it's like, okay, you're in the wrong place right now. You need to go to a physical therapist and get them in the right place. Low back pain can also be bigger as far as what the problem is. It could be something, you know, worst case scenario, a tumor in the bone. It could be a ruptured disc. It could be sciatica that is not due to muscular issues, but due to disc issues. It could be arthritis. It could be a kidney infection. It could be some infections of the spine. We've got to get this cleared up, so to speak, a diagnosis from a doctor so that, again, we make sure that we are the right person for them to see and what we're doing with them is the right thing. So some other things you want to consider is to make sure you have the equipment that you need for your client to safely do what they need to do for their back and other things as well. Getting up and down off the floor. You got a back problem, knees, hips, whatever. It's going to be hard to get up and down off the floor, which means you're not going to be able to take your client through some exercises or stretches that are on the floor because they can't get down there or they can't get up. What you might want to invest is there are pictures of massage tables on here, which are great. It makes it easier for clients to sit down on the table and lean back and do whatever quote-unquote floor exercises or stretches you would want them to do. You can also get treatment tables in different sizes. They're usually, I think, like 2-3 feet off the floor. So they can do the same thing, basically, and it's more stable. If you do get a massage table, I know this last bullet point says that you can get them for 150 bucks or even less on eBay. You got to be careful about the quality that you're getting. That not all tables are created equally, and not all tables can handle a heavy weight. So a really good quality massage table, such as Custom Crafts or you know, some of the other higher quality tables, they can run $600–700. But here's the thing: I know that's a lot of money, but they're safer tables. They're better built. They can hold maybe up to 350 pounds. And again, you may be dealing with a client who's overweight because of their back problem and vice versa. And you got to make sure that you get a good quality table. Some of these aluminum tables, like the one down here at the bottom, may not be a good way to go. They are not always very sturdy. And these little legs, oops, that was a highlighter, not a pencil, but these little legs can lose their ability to stay in place. I know it's got the little knob up here, but bottom line, I'm not going to beat the horse here. Don't go for the price, go for the quality. And because you do not want your client who already has back problems to get on a table that breaks. And it can happen. So just keep that in mind. But something that will allow them to do some exercises where they can move from one exercise to the other without creating more back problems. So, anatomy. I love anatomy. Anatomy's just, you know, it's got all the good jokes, but it's just amazing how our body works and how it's designed and what it does. So kind of a little review of the spine. We know that there are 3 major sections. Technically, there's 4 sections of the spine. We've got the sacrum and the coccyx at the end. The tailbone down here. But so typically we tend to focus more on cervical, thoracic, and lumbar spine. But you can have sacral, sacral issues, you know, so we don't want to really forget about that. But you've got 7 vertebrae in the cervical area, 12 in the thoracic, and 5 in the lumbar. So I always tell people you're having breakfast at 7, lunch at 12, and dinner at 5, which still may be early for some of you guys, but it's just a little memory device. The nerves that run through your spine, we've got this, of course, the spinal nerve, the spinal cord that goes through there, and actually let me switch slides. So the spinal cord goes through the vertebral foramen right here. And if you had a side view, and I'm going to attempt to draw, which I'm bad anyway, but I'm also kind of using a computer. So let me do that. Oh, that was right. Sorry. And then we've got another vertebrae here. And okay, so here's your vertebrae, 2 vertebrae, and then we've got the disc. It's not going to let me really draw the disc because of the spacing, but the disc is going to be right in here. And we've got this opening right here. That is the intervertebral foramen, inter meaning between. So foramen is Greek or Latin for whole. So we have the big vertebral foramen, which is where the spinal cord passes through each vertebrae. And then if you look at a side view, which is what I attempted to draw, you also have an opening in between the vertebrae, and that's where the spinal nerves that branch off from the spinal cord come out. So you can kind of see how if you have a herniated disc, people call it a slip disc. That is incorrect, but it's layman term. The discs do not slip. The vertebrae can slip, we'll talk about that later, but the discs do not slip. What they do is bulge. And they bulge because pressure is being put on one side of the vertebrae constantly. So I compare it to if you have a balloon and you've got your left hand under the balloon, your right hand on top of the balloon, and you squeeze your hands together, the balloon's going to spread out evenly. And if the balloon is your disc, then that is just normal everyday compression on those discs. But if you squeeze the balloon more on one side, so it bulges on the other side, so your balloon is now doing, and again, it's not going to let me get in there, your balloon is kind of doing this. That is a herniated disc. All the propulsus, the annulus and the nucleus propulsus, which is the jelly-like stuff that's inside your disc, starts to bulge out to one side. So if your disc or if your vertebrae are shifted where you're shifting more of your weight on the right side of two vertebrae, and that means that the herniation is going to bulge out on the left side. So tending to use one side more than the other, tending to shift your weight to one leg and causing you to laterally flex your spine constantly over and over and over again can start to lead to these curvatures in the spine, and those curvatures cause the disc to herniate. When it keeps pushing and pushing and pushing, so you're squeezing that balloon over and over and over again, and it's bulging on that one side, and eventually one day the walls of the balloon, so to speak, or the walls of the disc say, well, we can't take the pressure anymore, and it ruptures. Then all of a sudden you have very little, if any, space in between those two vertebrae. And so the way I explain to my students is you've got a pillow inside a pillowcase in between your vertebrae. You've just ruptured your disc, so that means the pillow is gone, and all you have left is the pillowcase between your vertebrae. That's what a ruptured disc will do. And so that means that now they've got less space in between those vertebrae, and more likely they're going to have rubbing of bone eventually, which can lead to arthritis. And that means that these nerves that are coming out of the intervertebral foramen are now being compressed. So that creates that nerve paresthesia, the tingling, the numbness, the burning sensation that radiates down a leg or radiates down an arm because that nerve is getting compressed somehow. And if it's because of a disc issue, they may need to go in there and kind of lift the vertebrae a little bit and create somehow, some way, a little space in between there to take that pressure off. We'll talk about some other disorders later. But that's the biggie, the herniated and the ruptured disc. And that's why it's so important for us to know which way is the disc rupture or herniated so that we know to do the opposite movements. And that's where, even though we don't like hyperextension movement, the doctor or the PT may recommend it in order to get, if the disc was bulging in that direction, to get that disc to kind of work its way back if it can. But that's got to come from the doctor or the PT that was working with that person. Otherwise, we don't lack hyperextension of the spine. So we also have, this is the anterior view. So this is the body of the vertebrae. Sorry, get my thoughts together. So right here on top of the body is where that disc sits. So if your disc starts bulging this way, it is hitting the spinal cord and starting to really cause some neurological issues. And if these compress these nerves long enough, you can actually lose function of that limb and permanently damage that nerve. So that's why all of this is very important. You've got your pedicle, which is right here. It connects the body of the vertebrae to the transverse process, which is right here. And then we have the lamina, which connects the transverse process to the spinous process. So, and you can actually sort of kind of figure out where your lamina is. You can't actually touch it because we have those deep, deep muscles of the back of the spine back there. But if you find your spinous process, just take one of your hands and lay your first, second, third, and or your pinky finger on your vertebrae. You can feel like several vertebrae at one time. And then just move your hands a little laterally. You can feel them dip a little bit. And that's getting into that lamina groove area. And that runs all up and down the vertebrae. And we got to remember, we got a lot of muscles that attach to the spinous process. We got muscles that attach to the transverse process. And when one side is tight and pulling in one direction, the other side is going to be weak. And that's what can shift the vertebrae into a position where ultimately the disc is going to shift itself, and that is going to lead to herniation. So we got to understand this part so that we know what we can do to help our client within our scope of practice. So then we've got the injury or degeneration cycle, and it is cyclical. So muscle imbalances, and this is something I preach to my students, and it takes a while for people to really understand this sometimes, is none of us have perfect muscular balances, meaning your left leg and your right leg are the same strength and flexibility, or your quads versus your hamstrings are balanced appropriately. And so body positions, and if you ever get a chance to take a postural analysis course, I would definitely get into that, because that dictates what your strength program should be focusing on, as well as your flexibility. They both go together, and a lot of times we get one, but we don't get the other. We focus on strength because there's a lack of strength in the hamstrings in relation to the quads, but we forget that wherever there's a weakened muscle, there's a tight muscle opposite to it. So that means that we also need to take a look at that flexibility program, and that's what we tend to not do. So muscle balances are all about strength and flexibility. And understanding that anatomy and all that good stuff, that's what I love, because it's that puzzle. It's pieces of the puzzle trying to figure out what's going on with your client. But we do know that, for example, hip flexors are tight, then that is going to cause an anterior pelvic tilt in most situations. And that anterior pelvic tilt means that we are now going to have an excessive lordotic curve in the lower back. It also means the glutes, especially glute maximus, and the hamstrings are weak. So you say, oh, well, let's stretch the hip flexors. Well, that's great. But if you never strengthen the hamstrings and the glute max, then they're always going to get back into that anterior pelvic tilt as soon as they move. So we got to look at both. And this is where the concept kind of gets challenging, is we tend to do balanced strength training programs and balanced flexibility programs. And we shouldn't be. And what I mean by that is if you do just 3 sets of 10 at the same weight on your right quads as the left quad, well, the weaker side's never going to get stronger, or equal, I shouldn't say stronger, but equal to the other side, because you're keeping everything balanced. Our bodies are out of balance. Therefore, our strength and flexibility programs should also be out of balance so that we ultimately correct the problem. And we don't do that. So, you know, if you're looking at flexibility, say your right hip flexor is tighter than your left hip flexor. Well, instead of doing the same number of repetitions and the same hold times on both legs, you should either do more stretches, repetitions on the tighter leg, or hold each stretch repetition for a longer period of time than the side that's not as tight. So it's the kind of blow your mind kind of thing, because we're so used to keeping everything the same. And when you start to, you know, do something different with your sets or reps or your hold times, all of a sudden it's like, wow, that's not a complete program. But your client will start to see either the tighter side or the weaker side starting to catch up and starting to correct itself. So keep that in mind, because muscle imbalances lead to movement modifications and posture modifications that and compensation, which eventually lead to your body saying, oh, well, we've been doing it this way all this time, so this must be our normal movement pattern, and we don't get a good motor learning technique for our daily activities. And that's where it's really hard to break old habits with your clients. And we've all talked about, if you watch a toddler who's just learning how to walk, squat down and pick something up, they have such proper form. What happens to us as adults? Well, we kind of get lazy. We do the quickest, fastest movement, which is not always the best way to do it. And all of a sudden that becomes our new movement pattern for that motion. And we need to break that, because those poor habits lead to changes in our forces on the joints, on the muscles. Proprioception starts to get affected. And then because of all of that, you start to have some joint degeneration, which leads to the pain and the inflammation, which goes back to the muscle imbalances. So it's this vicious cycle. And muscle imbalances, in my humble opinion, is where we need to start. Because these other things might fall into place a little bit easier if we start to correct these muscle imbalances. And to correct the muscle imbalances, like we said, we got to imbalance the strength and the flexibility programs to compensate. So I strongly encourage you, again, to consider taking a postural analysis type continuing ed to really, really learn about that. So some goals for working with seniors who do have low back issues. Find out what movements hurt, what postures hurt. Are they the person who can't sit for long periods of time because their back starts to bother them? What do they do when their back starts to bother them? How do they change their posture? And also, what makes it feel better? What are they doing that makes it feel better? Because sometimes that may be a temporary fix, and what they're doing to make it feel better may actually ultimately long-term make it worse. Develop corrective exercises to improve the movement patterns. And this sometimes, like we've said before, can mean going back to the basics, because we've got to break those old movement patterns. Build total body joint stability and really use good cues that your client understands, because you may see them later on walking on a treadmill or riding a stationary bike and they're losing that form, and you want to give them that cue and they're like, oh, I know what that is, and they correct themselves to the point that eventually they'll start to realize when they're not in proper position. So good cues, short, sweet, and simple, designed for your older adults to understand it. And develop that functional core strength. So again, proper posture, oops, I skipped one, builds the total body joint stability, because, sorry about that, you get their stability and they should be using their core correctly. And so reminding them of what it feels like to contract or engage the core. And we need to tell people what is core, because a lot of times people think core is just the abs. It is the abs, yes. It's also all of those back muscles. Eventually, you're getting upper back muscles in there, because a lot of people are weak in their upper back, and that affects their posture. Glutes are going to be involved in that. It's, basically from, base of the neck to the hips is what really core is, because everything is connected. So strengthen movement patterns that reflect tasks of daily living, and let them know what daily living tasks they're working on, because again, it's that repetition that's going to help them learn how to eventually correct their own postural issues, which we want our clients to be self-reliant eventually. So the goal of the exercise program should always be to carry over strength, endurance, and stability, and also just general combined movement of the body into the real world. So the traditional exercise programs actually sometimes contribute to lower back disorders instead of improving it, because when you're working isolated muscles or just one or two muscles, we don't move that way in our daily lives. And I remember eons ago, back in the dark ages, when I graduated from exercise science with my bachelor's degree, things have changed so much. And we used to, focus on strength training machines and exercises and biceps and quads, and it doesn't help. You can have a very strong quad muscle, but if your quad muscle doesn't know how to work with the other muscles of the leg and the hip, then you're still not going to move right. And so that's what we want to focus on. So when creating an exercise program, make sure to evaluate whether it's improving spine movement or making things worse. So communicate with your client and let your client know it's okay to say it hurts, because otherwise I'm not going to know, and we're going to keep hurting it because you're not communicating to me. So some common low back disorders. I mentioned earlier that we would talk about some specific things that are going on with the back and learn more about those. So some chronic issues that your seniors may be dealing with could be stenosis issues. We'll talk about each one of these. Spondylosis, disc degeneration and herniation, spondylolysis, spondylolisthesis. Those are always fun to say. You'll have a test on that later. I'm kidding. Sciatica or piriformis syndrome, and then coccyx injuries. So let's look at spinal stenosis. Spinal stenosis is where those foramens that we were talking about, whether it's the vertebral foramen where the spinal cord goes through, or the intervertebral foramen where the spinal nerves branch off from the spinal cord and go to whatever organ or muscle that it needs to get to, starts to narrow. And so as it narrows, it starts to put pressure on the nerve and starts compressing it. And sometimes this happens because of arthritic issues. Sometimes it happens because of injuries. If you go back to your cellular anatomy, we have your osteoblasts, your osteocytes, your bone cells. And so sometimes damage occurs in a bone, and sometimes the bone heals itself too much, and you get too much bone narrowing. It can happen in the neck. Especially if you've had repeated neck injuries or you had a really bad accident that caused whiplash or something like that. But it can also happen in the lower back, which is interesting because those are your two parts of the spine that have normal lordotic curves. So hyperextension, hyper neck extension, those are not good for that area of the spine and can start to degenerate it. Your symptoms for spinal stenosis, the symptoms develop slowly because the bone is slowly overgrowing and the opening is narrowing. So sometimes people don't really notice it until all of a sudden they're starting to get this tingling and numbness going on. So they are sporadic as opposed to continuous symptoms, because certain positions will relieve the pressure on the nerve and certain positions will make it worse. They occur during certain activities such as walking or biking because of the muscle movements, and then remembering that we've got muscles attaching to the vertebrae in various places, so those movements of those muscles may start to pull on the vertebrae, and that indirectly will start to cause shifting and more compression. The symptoms are typically relieved by rest. So these are the people who say, I can't stand, sometimes. They're the people who say, I can't stand for long periods of time, I need to sit because my back's bothering me. Or they tend to flex forward and lean on things. And I always think of Kroger used to have senior discount day on Wednesdays many moons ago. And I always told my students, go to Kroger on Wednesday and you'll see all kinds of different issues, that you'll see with your older clients because you're there. And I always referred to this as the grocery cart physician. The person who maybe doesn't even need a grocery cart, but they need, not for their things that they're buying, but they need it because they need to lean on the grocery cart to relieve pressure on their back. and that is a sign that they may have spinal stenosis. In extreme cases, they may need to remove that little part of the vertebrae that connects the transverse process to the spinous process that we were looking at earlier, a laminectomy. So they're removing the lamina. That's very, very extreme. I think everybody knows that surgery is the last option, especially when it comes to back and feet, because, you know, it's a big surgery. So that is a discussion they're going to have with their doctors as far as whether that is the only thing left to try. Some exercises that may help, core stabilization exercises for obvious reasons, walking, swimming, or even water aerobics, cycling, low impact exercises. So again, just to remind everybody, low impact has nothing to do with the intensity. It has to do with one foot being on the ground at all times. So running is high impact, walking is low impact. Yoga and Pilates. However, you got to be aware of the person who teaches the yoga and the Pilates classes, because some of the moves that are done may not be good movements for your client. And so some education needs to go on, maybe with the yoga or Pilates instructor, and make sure that they know that this person has spinal stenosis, and let the client know or the class participant know what movements need to be avoided. You know, they're not that they're bad movements for people, but they may not be good movements for somebody with spinal stenosis. And then Tai Chi, that helps to work on balance and core. It's a great thing to have them try, and that may be because it's slow moving and it's balanced. That might be a good starting point if they're a little afraid of the pain from their stenosis. And then shorter but more frequent walks, as long as the walks don't make the pain worse. So instead of saying, oh, you got to do a 30-minute walking session, maybe break it up into a couple of 10-minute walking sessions. And, you know, sometimes walking uphill may take, you know, less pressure because it's kind of the same position as the grocery cart position, but we still need to be aware of gravity, pulling on it more. But if they're exercising outside, taking their walks outside, they may need to look at flatter areas if at all possible. Now, spondylosis. This is one of your 3 spondy conditions, and it basically is arthritis of the spine itself. And with the back pain, you know, this is just wear and tear of the spine itself, which is basically what arthritis is. But we usually think about arthritis in the knee or the ankle or the shoulder or something like that. But it can be a pretty painful thing to have in the spine. So spondylosis is a broad term meaning degeneration of the spinal column from any cause. It could be a chronic thing. It could be a disease. It could be traumatic, an injury, something like that. So in the more narrow sense, it's really kind of referring to spinal osteoarthritis, which is the age-related wear and tear of the spinal column, which is typically the most common cause of spondylosis. So their back pain may either be very steady or sporadic. These are the people where it's, you know, as with any arthritis any place else, they're stiff first thing in the morning, or they're stiff when they've been sitting or not moving for long periods of time because that synovial fluid just isn't circulating as well. Same thing when it's in the spine. They're just very stiff in the morning, which also means time of day for their exercise may need to be considered when dealing with back issues. Pain and tenderness or numbness in the neck area. Lower back pain that runs down into the buttocks, the thighs, the pelvic area, because you're getting wear and tear of the bones. You're going to be getting some nerve compressions in there as well, which can lead to the next bullet point, the weakness or the numbness in the legs or the arms, and then difficulty bending or walking because everything's stiff, and it hurts again if their nerves are going to be involved. So some exercises for spondylosis or arthritis in the spine, doing some nice pelvic tilts. And you can see in this picture, this guy has a very nice sturdy treatment table. It's not a massage table, it's a treatment table, which is great, but again, they're a little pricier. But doing some knee to chest stretches to help work on the excessive lordotic curve of the lower vertebrae and trying to stretch out those lower back muscles a little bit. If you keep the glutes on the table, which his are lifted, which is great, if you keep the glutes on the table, you're stretching gluteus maximus more than you're stretching quadratus lumborum or rectus spinae. So you need to curve the spine, so to speak, and the way to do that is to lift the glutes up off the table so you're pulling your knees in enough that the glutes come up. So sometimes people can't do that, both knees at the same time, so one knee at a time is fine. But you got to get those glutes off the table in order to really stretch out the rectus spinae and quadratus lumborum, the lower back. Bridging exercises, because it helps strengthen the glutes. It helps work on core, and so keep in mind, if your person can only lift off the table a little bit, but they're maintaining proper position, that is your starting point. And then for some people, back extensions, but anytime you're looking at any, now we're not saying hyperextension, okay? We're saying back extension exercises. So we're not talking Supermans. Supermans are where you're lying down on your stomach and you lift the arms and the legs up. That is hyperextending, and that's not what we're talking about. We're just talking, you can use the angled bench where the person lowers their hips or at the edge or the top edge of the bench, and their head and upper back bend forward or flex forward, and then they lift their body up, but they only lift it high enough to where the body is in a nice straight line. That is a back extension. If they go any further up and start to arch their back, that is a hyperextension, and that's not what we want to do. So back extensions, dead bugs, the dead bug exercise, the quadruped exercise, all of those would be great for the spondy condition. So keep that in mind that there is a difference, a big difference between back extension and back hyperextension, and we want to avoid the hyperextension. Your disc degeneration, we talked quite a bit about that, so, but now we got some really great pictures. A lot of times people get upset with their doctors because the doctor wants to do an x-ray first, and they're like, just do an MRI. Well, the x-ray can tell the doctor a lot, and it can determine whether an MRI even needs to be done. So up the top here, we got a nice normal disc. The next level, they're showing you a degenerating disc. Then you've got the bulging disc right here. So there's your balloon that's bulging out to one side. The bulging and the herniation, kind of one and the same, but the herniation is just, you know, you're getting some pretty big movement of that gel inside your disc. And then you can have the ruptured disc or a thinning disc. And what the x-ray starts to show is, look at this space here, and let's pretend like this is a normal disc here. And here, whoops, move my whole circle there. So all of these, let's just say these are all normal discs, and you see the space. But then you get down here, and you don't see as much space. The disc does not show on the x-ray, but the vertebrae does, and the space in between the vertebrae showing where the disc would be, if you could see it, is also telling the doctor a lot. So that x-ray is like, okay, if I'm seeing an equal space between all of your vertebrae, your back issue is not a disc issue. So we may or may not need to do an MRI to find out what's going on. If the doctor looks at the x-ray and says, well, see up at the top up here, you've got nice, good spacing here. And then when we get about right here, the space in between the vertebrae is less. So something's going on with the disc there. So the X-ray does give the doctor a lot of information, and we want to let our clients know when they complain about getting the X-ray, why not just do the MRI, because it, you know, like I said, it lets the doctor know what direction to go in. So the lumbar spine, because that are the larger vertebrae, and they're larger because that's where we bear a lot of our body weight, it accounts for most of these disc degeneration issues because we just abuse the heck out of our lower back sometimes. And it's associated with a flexion-based lifestyle, constantly flexing forward, using the back, not using the glutes, maybe because the glutes are weak, maybe the glutes are weak because of the poor form. It's that chicken and the egg thing. So I kind of got ahead on this one, but the herniated or slip disc is used interchangeably, and sometimes ruptured disc is used when it really isn't ruptured, it's herniated. So this, again, is why we need to get the information from the doctor as to what exactly is going on. And then after the age of 50, a common deterioration and weakening of the spine can start to lead to a lot of these problems. And so we have to be careful with our back, or our spines and the back. In addition, you have women who are going into menopause, and depending on genetics, depending on medications they're taking that may hasten osteoporosis, this is something that we need to be aware of as well, because that can also contribute, obviously, to a lot of back problems. One of the conditions, herniated disc, we talked about where the disc fluid, that gel, starts to leak out and you lose your pillow out of the pillowcase. And the result's going to be the low back pain that can extend to the leg and the foot, mainly because the spinal nerves that are in the lower back migrate and innervate muscles of the lower body. And sciatic nerve is that biggie one. And that one runs down the posterior side. We'll talk about piriformis issues in a little bit, but if it's a disc and they're having that tingling and numbness going down their leg, again, out of scope of practice for us fitness professionals, we need to get them to the doctor, a PT. You know, even if they saw the PT a long time ago and they're still having the issue, they may need to go back to their doctor or go back to physical therapy before they start to work with us fitness professionals, because extreme cases can lead to paralysis, and we don't want that. So what do we need to do if we are cleared to work with that client because their herniated disc is chronic, and it's like, why go back to PT? It's chronic. They need to work on their movements with us. So we need to avoid repeated flexion, especially full flexion movement, and that includes stretching positions, and it includes, you know, situations such as curl up and crunches, because again, you don't have to focus on those abs to work the abs. You engage the core in your other exercises and movements, and that will still work the abs. Prolonged sitting. In fact, it's interesting that studies, you know, you see these studies that show, okay, after sitting for a certain period of time, if you get up and move around, then that will help your back or help this, that, and the other thing. Well, the other thing that it helps, and there was a study that came out, it was done by University of Georgia, probably about 4 or 5 years ago, and they found that in college students, and I think it was mainly college females, it also helps to reinvigorate you better than a cup of coffee. And so they came up with this number, and it was interesting. It was like, for every 47 minutes of sitting, you need to get up and walk for 12 minutes, and that actually stimulates your brain and your alertness better than a cup of coffee. And I was like, wow. So it's not just good for the body, it's good for the mind. So get people to get up and move. Get people who are traveling in a car for a vacation or on an airplane, if they can, to get up and move periodically, or stop the car every hour. So yes, it makes your trip longer to get from point A to point B, but at least when you get to your destination, your back isn't hurting and preventing you from having fun if it's a vacation. So these are things to kind of keep in mind. And also too, you know, we're talking about older adults. lessens the risk of blood clots because they're getting up and moving around, keeps their other joints from getting so stiff. They're probably going to feel a lot better. And if they're the driver, a lot more alert, to get up and stop the car every once in a while. The second bullet point here, the location of the herniation is a function of the dominant direction of the load. So remember, muscles attached to these vertebrae. So if it's lumbar vertebrae, it could be a quadratus lumborum issue going on. It could be they have one hip higher than the other. And yeah, maybe one hip is higher because they had hip replacement surgery. Well, let's get shoes that can accommodate for the leg length description. Let's see what's going on. Don't treat the symptoms, treat the cause. So find out what the cause is. And that, a lot of times, is going to involve the doctor. Especially avoid extreme flexion with rotation, these ab exercises to work the oblique, especially with the lever, with the leg out like this, you're increasing your lever, which is the length of the leg, which is going to put more torque or rotational force on that joint, which is going to be the back and the hip. So that's why we don't like to straighten the legs out, one or both legs at a time without any support. It's not good, and most people can't handle that. So this also includes daily activities. Let's think about daily activities where you flex and rotate. Well, depending on your washer and your dryer setup, if you have a front load washer and your dryer is above, it's a stacked unit, depending on the shape of your room and what you're having to do, you may be rotating to get one side to get the wash out to load it in the dryer, or if it's side by side. You've got a top load washer and a front load dryer. These are all things that we don't always think about in our daily activities that maybe, we need to evaluate to teach them how to move properly so they don't make their back situation worse. So sometimes doing a home evaluation from a fitness standpoint might be very, very helpful. When you're exercising with the herniated disc, some things to be aware of. Make sure if they're taking yoga classes or Pilates, we talked about this a little while ago, that there are some poses or stretches that may make their back pain worse. And they need to work with that yoga or Pilates instructor to work through that, maybe come up with some other options. There's always alternatives and modifications that can be made. You just have to communicate that to the instructor. Dynamic core stabilization exercises helps improve posture, flexibility, strength. I think we've kind of beaten that horse quite a bit. Moderate aerobic activity, and not going until they are exhausted, because we know that that changes your form because you're tired. So we don't want our clients to go to the point of exhaustion with their exercises. But low impact type exercises, walking, biking, swimming. Recumbent bikes are usually more comfortable than the stationary bikes, sometimes whether you have back problems or not. The new step bike, which is a recumbent bike stepper combination, may also feel better if your facility has one of those. We have to be, and when we say moderate aerobic exercise, we're talking about intensity also. Vigorous intensity and back problems don't always work well, because the faster you move to get your heart rate up higher, the more likely you can lose your form. So they may need to bring their intensity down a little bit. And when beginning an aerobic program, 10 minutes a day or 10-minute blips. American College of Sports Medicine says, we'd love to get people up to 20 to 60 minutes of exercise for cardio, but not everybody needs to start there. Not everybody needs to be there. So they do say that several 10-minute bouts a day of cardio that equals to at least 30 minutes or 20 minutes, depending on their fitness level, is also okay. It's better than nothing. And especially if your person has been sedentary, they probably just need to start with 10 minutes of walking, easy walking. A lot of times it's to help build their confidence that they can do this without their back hurting. and start to gradually progress the client to where maybe they're going a little longer and maybe bumping their intensity up eventually so that they do start to get the cardiovascular benefits from it. Because whether your client has back problems or not, they may still have diabetes or heart problems or cholesterol problems, things that they still need to do some kind of cardio in order to live, you know, but without the pain. So we've got to come up with some of these compromises, and we don't want to forget about other health issues where exercise really needs to be done to help control those health issues. We just may need to modify it for the orthopedic type problems that they have. So speaking of, let's talk about some things that we need to avoid. Avoid exercises that include hip or spinal flexion, especially if it has resistance or rotation in it. Good mornings and deadlifts, unless they've got really, really good form. And this is where you can do the modified good mornings where the knees are slightly bent, but you know, I see people, and myself included, I was noticing that I was having some back issues because I realized, gosh, my glutes are so weak because I wasn't watching my form like I should. So we're not saying don't necessarily do these exercises. We're saying they just got to have some really, 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 really good form, and most of our older adults don't. So that's why we kind of have this on this list. Bicycle crunches and windmills, just nobody needs to do that. So don't do this. Overhead weightlifting, and here's the reason why. Military presses, lat pull downs, you know, anything, shoulder presses, because when we struggle with the weight, we tend to hyperextend the back. And also, too, when your arms are in the air with the weight, you're putting, even, we got to remember levers and torque. Your torque has increased on your shoulders and on your spine because your lever, which is now your arms and the weight, have lengthened above your head. So you've got direct pressure hitting those discs, and it's just not a good thing to do, and it's typically not functional movements anyway. I mean, how often do you push something directly over your head? Not often. We also need to be careful with crunches, and we need to avoid the straight-legged lift. Everybody should, pretty much, because most people can't do it. Even your very fit, very strong people can't do it with proper form without placing some kind of stress on the back. I mean, they may not admit it, but it's happening. Standing stretch hamstrings because it's unsupported forward flexion. They can modify. We're not saying don't stretch the hamstrings. We're just saying don't stretch hamstrings by standing and flexing forward. Have them instead lie down on their back, on a table, on the floor, you know, whatever way they can do it, and take one leg, keep one knee bent, right knee bent, left leg comes straight up in the air. Your back is supported, and you're still stretching the hamstring. And then high impact activities, just because of the pounding that's going on, and that pounding is hitting the vertebrae and the disc. So let's get into another spondy condition, spondylolysis. Now, spondylolysis and spondylolisthesis are two different things that are going on. Spondylolysis, always think of lyso. Lyso breaks down the grease. Spondylolysis is where you have bone breaking down, so to speak, leading to stress fractures in the spine. And it's usually in the pars interarticularis, or the vertebral arch. So looking at the spinous process, right in this area is where the bone is going to be the thinnest and easily fractured. Usually this problem happens in the lumbar vertebrae, especially around L4, L5, but it can also occur in the cervical vertebrae. And lots and lots of hyperextension, not a good thing, and that can cause some of it, but also the bones just breaking down, so it's a combination of things that can lead to this. So I mentioned that this is different from oops, that's another slide coming up. Sorry, got ahead of myself. So first, let's look at some symptoms, and then we'll compare it to spondylolisthesis. So some symptoms of spondylolysis, they usually report spontaneous. I mean, all of a sudden, they just have unilateral back pain, and it's right around where the belt is, because that's right around those lumbar vertebrae, especially L4, L5. It's made worse by arching, because they're arching and putting pressure of the spinous process above the affected spinous process, and they're pushing it down, and they're affecting this fracture even more so. So standing or sitting, but they're arching, that will aggravate it because of the pressure of one spinous process bearing down on the affected. And then pain may radiate to the buttocks of the thigh because you're starting to get all those nerves. You get a big group of nerves called the caudae equini that branch out from the sacrum. You've got those little holes in the sacrum where you've got about 5 vertebrae that are fused together, and those holes are where some of these nerves come out of the caudae equini. And it's called that because these nerves come out looking like a horse's tail. Therefore, caudae equini. And all of these can start to get impinged and affected before they start to branch out from the spinal column out into that area. So, and like we said, they innervate the lower body. So lower body starts to get that paresthesia, tingling, numbness, burning pain going on. So now let's look at the difference between spondylolysis and spondylolisthesis. Spondylolysis, we mentioned, is little fractures. Hairline fractures between the bony arch at the back of the spine and the facet joints. And the facet joints help to connect the vertebrae above and the vertebrae below to help keep the vertebrae in alignment rotation-wise. Spondylolisthesis is when a vertebrae starts slipping forward. And I always tell my students, I remember spondylolisthesis is a vertebrae slipping forward because your tongue is slipping all over your teeth while you're trying to say it, spondylolisthesis. Now, this is not, the slippage forward is not a disc. Discs don't slip, but vertebrae can. And this happens a lot of times from people who do a lot of hyperextension, gymnasts, ice skaters, sometimes high jumpers because of the arch in the back, and they just keep putting that pressure and pressure and pressure on what becomes the apex or the top part of that bend, and that's the vertebrae that tends to start slipping forward. And we've got a picture of that coming up right now. So this right here, this is slipped forward right in this area. So again, it's not the disc slipping, the disc is shifting because it's actually attached to the body of the vertebrae. But this vertebrae is shifting forward, and it's shifting the disc, not slipping the disc, but it's shifting the disc. So lots of problems. And let's not forget, you got your spinal cord in here. So now you've got a shift of bone hitting that spinal cord, and that's just all kinds of pain. So there are other conditions such as bone tumors and things like that that can cause it, traumatic type injuries, that can cause it, but also lots of hyperextension. And I just remember this one gymnast in the Olympics, whichever Olympics this was, and her signature move on the balance beam was she would have her chin resting on the beam and her upper body resting on the beam, and she would hold on underneath it, and then she would arch her back, bringing her feet above her head, and she could stare at her feet above her head touching the beam. And later on, she developed spondylolisthesis, and it was like when she was in her 20s, she could barely walk because of all the damage that she did from all that hyperextension. Not good. So this is a big reason why we don't like hyperextension in daily activities or exercises. Extension is okay, hyperextension is not. So let's talk about some of the exercises that can actually help people who have one of these spondy conditions. Of course, working on core stabilization. And that's going to be through all kinds of different exercises and movements. Make sure, and even if you have to stop them and say, well, hold on, don't do that other repetition. Whatever your cue is, engage the core. Okay, now do your movement. And you keep doing that with them. Eventually, they'll be able to recognize for themselves when they're not in proper position. The dead bug exercise, which is this top picture here, and he's doing a little bit of a modification to it, which is completely fine to work on core stabilization. Bugs die when they flip over on their back and they can't get flipped back over. And I'm sure they're thinking, oops, shouldn't have done that. Now I'm going to die in this position. But that's where it gets its name. So its legs are up in the air. So our legs are up in the air. The back is supported. The knees are bent at 90 degrees. And all he's doing is putting some pressure on his knees for an isometric contraction here. So the legs aren't moving, the arms aren't moving, and that creates an engagement of the core muscles to help work on core stabilization. Eventually, planking. I don't know if y'all remember what planking was, the big thing, and people would take pictures of themselves planking in all kinds of weird places. And planking is okay, but the problem is our arms and legs move and at some point in time. So all these stabilization exercises where the legs and the arms are not moving in order to work on core eventually need to progress where you do move your arms and maintain core, and then move your legs while maintaining core, and then you can get them to where they're moving both arms and legs while maintaining core. So what I mean by that is the progression is once they've got good core stability, they can then bring their legs, their feet to the floor, and now they're maintaining neutral. And that's the key, is neutral, not back flat on the floor, not back arch, but spine and neutral. And then have them raise their arms up one at a time over the head while maintaining neutral. They got that down, great. Now don't move the arms, and now one leg at a time, keeping the knees bent at 90 degrees. We're not straightening the knees out. Tap the heels one leg at a time while maintaining core. Okay, great. When they master that, now you alternate arms and legs. So right leg, left arm moving, and vice versa, maintaining core. That is a progression on this. So teaching those pelvic tilts, teaching a pelvic clock. And they can do that while laying down on the floor or sitting in chair, where if neutral is where your pelvis, so to speak, is pointing straight up at 12. They arch the back a little bit to, point it at 11 o'clock, and then they flatten the back to point the pelvis at 1 o'clock, and they keep doing that movement, anterior, posterior, pelvic tilt, but they make the movement smaller and smaller and smaller until they find neutral. And they know when they find neutral, if they're standing, they'll feel that there's no weight on one particular part of their body. Everything feels like it's spread out evenly. Or if they're sitting, of course, it's just going to be from the hips up, but they're not feeling any stress placed on any one particular part of the body. And that's neutral for them. And that's what they need to try to find each time they get into these exercises until it just becomes a habit. The quadruped exercise, we Southerners call it the hunter dog. And that's when your person can progress to being on their hands and knees. And they got to get into that neutral position. So they may need to do that pelvic clock first in order to find neutral. And once they can hold that position, maintaining neutral, then you will gradually start bringing one arm up at a time by their ear, as close to the ear as they can in front of them, and bring it back down to the floor. And they will alternate that, maintaining neutral. Just stop them and reposition them when they start to lose their form or when they fatigue. Once they can master that, and that may take a day, a week, a month, whatever, then you keep the hands on the floor maintain that neutral position, and now they straighten one leg out behind them, one leg at a time, no other way to do it, unless they're magical, and bring that back down. But they got to maintain that neutral, and you got to be watching them to get them to stop, reposition when they lose that form. When they can master the legs by themselves, they can master the arms by themselves, then you can start add opposite arm, opposite leg, lifting and lowering. Then you can progress them to where maybe you're on a dynadisc or something unstable, and progress them from there. You can even do quadrupeds on a exercise ball, a large stability ball, to help them with their positioning if it really aggravates their back. Again, the key is not to hyperextend the back, because that's what they're going to want to do. And then double knee to chest stretches, gluteal stretches, all of these can help these spondy conditions. The worst thing to do, and this is a challenge, this picture right here, because a lot of people like to play golf. I don't know why. Trying to get the smallest ball in the world into the smallest hole on the biggest playing field is very frustrating to me, but there are people out there who like it. Any swinging sport, softball, baseball, tennis, because everybody tends to favor one rotation because they're right-handed or left-handed, and that rotation and flexion, which is what this guy's doing in this golf swing, this is why we see a lot of golfers and tennis players and people like that with spondy conditions and back problems, because it's always one-sided. So they may need to limit or eliminate those activities, and that's going to be a challenge if they really enjoy it. Of course, they may not be enjoying it if their back's killing them. This bottom picture, that's the Superman I was talking about. We don't lack Superman because, as you can see, look at that hyperextension right there. There are modifications that you can do to this, but the challenge is whenever we lie down on our stomach, like this in this prone position, right off the bat, we hyperextend the spine. So placing a bolster or something underneath a pillow or something underneath the person right at the waistline may help to bring that back into neutral, and then just lift one arm at a time, not the arms and the legs at the same time. Or just do the quadruped dog. That's really the better, safer thing to do. So we do want to avoid anything that may end up putting us into that hyperextended position. So let's shift gears now, looking at sciatica versus piriformis syndrome. Your piriformis is one of the deep 6 hip rotator muscles, and it's deep to the glute muscles, and it runs basically from the sacrum and the iliac crest, the most lateral posterior side, out, angling towards the greater trochanter of the femur. So it kind of runs almost horizontally. But there are 5 other muscles that are also in there. We have the gemellus superior, gemellus inferior, obturatus internus, obturator externus, and your quadratus femoris, not to be confused with quadratus, which is a lower back muscle. So you throw the piriformis in there and you have the deep 6 hip rotators. And they all work together to externally rotate the hip. Now, the piriformis is a little funky. When your hip is flexed, the piriformis actually internally rotates the hip. When the hip and the knee are straight or extended, it externally rotates the hip. So the other reason why we tend to focus on the piriformis more so than the other 5 hip rotators is because of where the sciatic nerve is located in relation to that muscle. So when you look at this next page, here's the piriformis muscle right here, and then you've got your other deep 6 hip rotators. This is gluteus minimus right here, it looks like. And the sciatic nerve runs inferior to the piriformis, and some people it runs through the piriformis muscle. Regardless, if the person is tight on external hip rotation when the hip is straight and the knee is straight, then it puts pressure on that sciatic nerve. So it's tightening the muscle, concentrically contracting the muscle, and that puts pressure on that nerve. So you do that all the time because of a postural issue, then you're going to have a lot of compression on that nerve, and it can lead to sciatic feelings where the pain is radiating down your leg. People feel that and they think, oh, it's a disc. Well, it might be. And that's why you got to go to the doctor to get it checked, get that x-ray. And remember we said that the space in between the vertebrae tells us what the discs are doing when you're looking at the x-ray of the spine. And if the space on all the vertebrae looks great, then the next thinking might be, okay, it could be piriformis muscle that's causing the problem. Let's get you to physical therapy and let's work on stretching this muscle. So the stretch on the right, this gentleman, because the hip is flexed at 90 degrees, remember the piriformis muscle internally rotates the knee. So to stretch it, we externally rotate the knee, which is what he is doing by gently pushing down on this leg with this hand right here to get it to externally rotate and stretch the muscle more. Now, if you do this on the floor and you pull, let's see, he's got his right leg, he's stretching this right piriformis in this picture, his left leg is just bracing. Now, I know some people lie down on the floor in the same position, and then in this case, they would pull the right leg towards the knee, and they'll say, well, I feel it in my glutes. It's like, well, yeah, you know, because the glute maximus extends the hip, and you're flexing the hip. So you're stretching the glutes also. So not to be confused with getting that piriformis, because they'll feel it in the non-stretching leg for the piriformis, and we want them to feel it in the piriformis of the leg that they're actually trying to stretch. That's what we're focusing on. So this can be corrected. We do tend to see this more in women because women have a more flared pelvis for childbirth. Yay. That's a good thing. Make sure that you don't break the pelvis as you're delivering your baby. But that flared pelvis tends to externally rotate the femur a little bit, and so women do tend to have more problems with the piriformis than men because of that. So keep that in mind, and that is, you know, stretching the muscle is going to be key to that if the piriformis is the problem for the sciatic nerve. So when we're looking at designing a healthy back program, you know, like we mentioned before, the primary goal of the program is to improve core stabilization. So with that core stabilization, their posture is going to be better, and stabilizing the core doesn't mean the arms and the legs are stabilized. It just means the core is stabilized. But you may need to start off not moving the arms and the legs so that they get the hang of it, and then you can start adding the arms and the legs while maintaining core stabilization. So we do want to make sure that the client exercises daily. They have a problem, and we need to get them to work on it daily. So we got to watch the sets and the repetitions that we give them initially so that they don't overdo it. The exercise must not increase pain. If it does, first look at their form. Make sure they're maintaining their proper form. And if they're not, correct it. Try the exercise again. And if that gets rid of the pain, then, you know, really remind them about their cues. If you correct them and it doesn't get rid of the pain, don't do that exercise. Something funky is going on. And if it starts to happen on more than one exercise, they need to go back to their doctor and see if something has changed. Avoid flexion first thing in the morning. You know, people were told many, many decades ago, hop out of bed and sit down, you know, flex forward and touch your toes first thing in the morning. That's not a good thing to do. Those people have back problems now. Let your body get warmed up. Do your normal routine, whatever you do in the morning, and warm your body up before you start doing anything. But again, that kind of goes back to what I was saying earlier. Time of day when you work with these clients with back problems and arthritis and all this stuff is very important. They probably don't need early morning appointments unless they've been up for a couple of hours already and are warmed up properly. Add walking to their routine. And when they're walking, they really need to work on concentrating on maintaining that core stabilization. So teach core stabilization first, either through the pelvic clock that I was mentioning earlier, the pelvic tilts, or, the pelvic tilts with the right hand over the left hand or vice versa, so the pinky and the thumb are touching, those kinds of things. And be patient with them. Those of you who work with seniors, especially some that are a little progressed with any kind of disease, physiological or physical, a lot of patients has to come around. They're scared, they're nervous, they don't want things to hurt worse, so they're a little skeptical at trying things initially. So start slowly, start with just a couple of things. And I even tell my students, when you're working with somebody who's younger or who's recuperating from an injury, start out with 1 or 2 exercises and then gradually add others. And if they start to have problems, you'll have a good idea which exercise or stretch it might be. And you can back off on that particular one. So be patient with them. When you hurt 24 hours a day, 7 days a week, they may not be the nicest, most pleasant people. And we just have to try to put ourselves in their shoes and understand that. So improving function, decreasing low back pain, some more guidelines. For proper preventative measures, a complete exercise program is necessary. You can't work on one muscle and avoid others, because we know that all of our muscles work together, whether, from head to toe. If something is primary mover, something is assisting either as an antagonist, as a synergist, or as a stabilizer. And that's why we've gotten away, like we mentioned earlier, from working individual muscles, or trying to focus on individual muscles, to looking at whole body movements. Taking medicine and lying in bed is the wrong thing to do. And some of these individuals may have been told decades ago that that was the right thing to do. So educating them, that's not what we do now anymore, because the more you lay around and do nothing, the more stiff you're going to get. Proper stretching, strengthening, body mechanics. We want to help keep the muscles strong. We don't want them to atrophy any more than they already are because of the aging process. Letting your muscles do nothing is the worst thing for them. So it doesn't need to be a full-fledged exercise program if they're having a bad day. Just getting them to do some gentle walking, moving around, it's amazing how much that can help, even if it's less than what they normally do, because they're having a bad day or, a flare-up of some sort. And maybe even get them into the pool. Now, I do want to mention one quick thing about getting people in the pool. It's very easy, because of being buoyant in the water, to forget about core activation. So we really need to keep reminding them over and over and over again, whatever your cue is, activate the core, engage the core, and make sure they're doing that in the pool as well. A lot of times people say, you can't get hurt in the pool. Well, you can. And it's, we just need to be very, very careful of that. And when they get out of the pool, and most pools nowadays are handicap accessible, so they may need to utilize the lift or the special stairs. They need to get out slowly, because they've been buoyant in the water. They need to gradually add gravity back to their body as they're getting out of the water. So let them get out of the water slowly to adjust to that gravity again. And then the last bullet point on here, match proper exercise with the low back condition that's causing the problem. And if you're not sure, then get with their physical therapist or their doctor who was working with them before. The PT is probably the best person to ask. Doctors fix the problem, and then they pass them on to the PTs to get them to work their magic. So PTs are great people to have in your back pocket to help you out. But make sure it's someone who worked with a client, because it may make your physical therapy friend a little uncomfortable if you're saying, hey, I've got a client, because they don't know who the client is. They don't know anything about them. So if your client client has worked with physical therapists, get that information and try to get in contact with that PT to gather as much information as you can to better help your client. And like we have been saying many times, your function starts with the core. We have the inner unit and the outer unit of the core. Your inner unit are muscles that are directly attached to the spine, like the diaphragm. Breathing is very important for core. Your multifidus transversalis muscle, your transverse abdominis muscle, that's the deeper of the abdominal muscles, your pelvic floor. We don't think about the pelvic floor sometimes, and you know, you got a lot of older adult females and males who may have incontinence issues for a variety of different reasons, and we forget that when we tilt the pelvis, we do tend to contract our pelvic floor muscles a little bit. So we don't want to forget about pelvic floor exercises when we're talking about core stabilization. And your female clients especially will love you because that may help them strengthen those muscles and help lessen their incontinence issues if it's a muscular issue. And then your global muscles, which make up the outer unit, are going to be your larger torque-producing muscles. So that's going to be your oblique, your internal and external oblique muscles, your rectus abdominis, the rectus spinae, quadratus lumborum, all of those good muscles that help to provide more general stability. That's why the core is so important, and helping with segmental control for those deeper muscles and general stability with the outer unit. And then as far as some exercises for mobility in the lower back, there is no evidence or research that shows that improving your lumbar range of motion improves performance or decreases pain. And actually, our movement, our rotational movement, really should come from the thorax. That is the most mobile part of the spine, of course, outside of the neck, but think about it, our ribs attach to the thoracic vertebrae, and our ribs have to move so that we can expand the lungs to breathe, right? So they got to move. The vertebrae are going to be more mobile in that area. We have 12 thoracic vertebrae for the 12 ribs. So what we really need to teach, because there are situations in our daily activities where you have to do rotation, but it should not come from the lower back or the lumbar area. It should come from the thorax area. So teaching thoracic rotation and working on thoracic mobility is what Joanna do. So overstretched muscle is a weak muscle. We've kind of talked about that already. Muscular weakness is the root of most back problems. So when you strengthen those core muscles, you're going to help with that muscle balance so that the agonist and antagonist can work together to help stabilize. Improving mobility of the hips and the shoulders will help improve performance. The lumbar should not be that rotational area. So your hips can move very well, the shoulders can move very well. The lumbar vertebrae are for stability, the thoracic vertebrae are for mobility. So the exercise that this woman is doing here is she is stabilizing her hips, placing one foot on this step up, placing the opposite hand on the wall, and what she's trying to do is rotate so her head, not her eyes, but her head can rotate with her body as far around as she can through the thorax area. So having the hand, her left hand behind her head, she's rotating her thorax to the left. Now, it's not going to get far. And I think that's where people are like, well, let me see how far I can go, because if some is good, more is better. And if some is good, more is not usually better when it comes to the body. And rotating too far, you're going to start bringing in the lumbar vertebrae, and that's not good because that's not what they're for. So some other things for core stabilization, ball squeezes. In this picture, you can't really see the whole thing right here, but facing the wall with his left arm only on the ball, facing forward and pushing the ball against the wall with that one arm. And that will help create a little bit of an isometric contraction to help, and you'll feel that throughout the whole core trying to stabilize. Make sure you don't hold your breath. The research shows that the heavier the weight you're lifting, the slower you should exhale, because that intra-abdominal pressure does help with some stability for the spine. But your client who has back problems should not be lifting close to max where they would need to worry about that. But they still need to be aware that they inhale, help control the stability of the spine, but they need to exhale as they lower the weight and then inhale again. So breathing isn't just to get some air in and out, it's also to help with the stability of the spine. Keep your chin up, and we're not saying stay positive, we're saying keep your chin up. Head posture. Now, you got to find out what's normal for your client, because if they have kyphosis, osteoporosis, something that's a bony issue that we can't change, that position that they're in may be their normal, and we don't want them to continue to go beyond that. So head position. I always tell my students, don't just give cues for the joint that you're moving or the joints that you're moving. You've got to give head to toe cues. Let the client know what should be moving. Let the client know what should be moving and how. With your progressions, start with seated exercises first, and then start to progress to standing. And then you might want to progress to unstable environments. And these are some examples of unstable environments. This is getting into isometric conditioning. So she's doing squat exercises with the band that is trying to pull her. Oops, I need to use a different color pen here. Let's use yellow. So trying to go pull her back this way when she's trying to maintain her position forward, so to speak, so she doesn't go flying back. And this will help. This is a progression to help them work more on core stability. Because another question that you may want to ask your client is, what normal fun things did you used to do that you no longer do anymore? And if they say, well, I hate crowds. Well, why do you hate crowds? Do you hate crowds because you hate, you don't have patience and you don't want to wait in line? Or do you hate crowds because you're afraid somebody's going to bump you and you're afraid you're going to fall? Because this will help work on core, but also balance a little bit. And if somebody does bump you while you're standing or walking, your core better be pretty good or you might end up falling. So these are all exercises that will help with that. Your anti-flexion exercise, now you're going to turn and face in the opposite direction, because again, the band's trying to pull you into flexion and you're trying to engage the core to pull back a little bit so you stay erect. So, and if you don't have an anchor, you can be the anchor for your client. Just make sure you're strong enough. Anti-lateral flexion, again, band's trying to pull her this way. She wants to maintain stability, so she's having to pull this way in the opposite direction. So these are all great exercises to add in as a advanced progression. And then anti-rotation, where you are keeping your hips forward and you're only rotating thorax. So she's rotating her arms just a little bit towards the anchor and then just a little bit away from the anchor. The movements are not large movements. And we need to emphasize that with our clients. More is not better, especially when it's coming to stability. So as a little summary here to help you out, because this is a lot of stuff. When you're looking at suggested exercises, the numbers across the top go with these numbers down here. So for example, for stenosis, we want to work on core stability, which that's going to be with all of them. We want to work on slow yoga, Pilates, or Tai Chi movement, and moderate low impact work. So that's 1, 2, 3. Or let's get down to spondylolisthesis. Again, we want core stability work, but now we need to look at dead bug exercises, pelvic tilt exercises, and spinal flexion needed chest type stretches. So this is a nice little handy chart to kind of summarize everything up for you guys because it's a lot of stuff. So that is the end of our webinar. So as promised, this slide was shown at the beginning. So just as a reminder here at the end, you have hopefully completed your webinar. So now that you're done, you're going to log into the Exercise Etc. website, go to the administration link at the top right of the screen and click on that, and then click on the Webinar on Demand certificate. Remember to choose the exact title, and the exact title of this webinar is Standing Tall, Exercise, and the Aging Spine. And once you find that, you're going to click on that, and you're going to take your short 20-question quiz, which is required. Once you have completed that, then the brief evaluation is next, and that is also required. And then you're going to fill out the fields for your name and all that good stuff. And again, make sure that your name is the same as it is on the certificate as it is with your credentialing organization. And your certificate, after you click submit, the completed certificate will be emailed to you. So make sure you save that somewhere on your computer so that you have access to it when you need it. And remember to complete this webinar and print out the certificate or save it by December 31st of the same year that you purchased this program, because some credentialing organizations will not accept certificates with next year's date on it when you submit. And your webinar quiz is based on the slides, on the PowerPoints, not all the other mumbo jumbo I gave you guys. So, you know, have your slides, your PowerPoint printout handy. And it is sequential, so the questions are in order as the slides. So good luck with that. Thank you for joining us, and we hope to let you listen to us again someday.